My God, nobody's hearing me. Okay, good morning. Welcome to the spring semester. You're going to enjoy this. GI is amazing. We have a lot of fan facts about GI, and it's an amazing system, by the way. It has more functions than the one that we realize it has. And we'll wait just one more minute for a little bit more, for more persons, and that's it. Okay, so about the fan fat of GI, how much saliva do we produce? Is it that important? Well, guess what? 32 ounces is winning. 10 ml is too little. 55 is too little. And of course, it's 32 ounces, and that's the correct answer. And GI system has its own nervous system, of course, and we're going to talk about that today. It does have it. But before we get started, that's the end of the pool. Thank you for being here and opening your camera. I am going to share our Blackboard. Let me see if we can do this here, because it's important to tell you that the GI module is very extensive. It's very long, and I need you to focus from day 0. Today, we're going to do a review, and it's going to be very helpful for everybody. But from day 0 and up to day 10 and 11, that's our Black Monday, we have a lot of content. So if you're not up to date where you're studying in your summaries, it's going to be difficult. At the end of the day, you're going to have so many things to review if you haven't done it, or you haven't done your short summaries in order to review 2 days before the exam. It's going to be a lot. So the way that I organize this, you're going to have a blueprint. Of course, this is the schedule summary. And you have a study guide that today we are going to be using for day 0. You have the osmosis list here completely. And I do recommend to do 184 questions in PANS Q Bank in osmosis. The way that you do it, you click on GI, history, formulating, applying basic science, and using diagnostic, and some of those will help you get some of the pathophysiology questions. If you get advantage of the 10 days that you have, you should do around 10 questions daily. That's the only thing I ask you to do using the osmosis bank. So here you have day 1, 0, 1, 2, and going forward. I'm just going to open, for example, days 1, and you're going to see here very short PowerPoints and some of the materials. So PDF, you don't need to go anywhere to look at it. And for each day, it's not available for you. It's hidden for students. You're going to have a case study. And depending on the schedule, everything is there that we're going to cover. Some students told me, what are we going to do? What are you going to base your evaluation on? It's going to be very similar to neurology, but please follow our schedule. Like, for example, in some days, I'm going to ask you, for example, you're the one who is going to elaborate the questions for the exam. So, for example, that's going to be one activity. For day 1, we're going to do just simple things as we did. For neurology, we're going to just focus on risk factors and symptoms, and you're by small groups working through the cases. So for tomorrow, my idea is not to lecture. I want you to read, see the videos, read, and go over the PowerPoints. My idea for tomorrow is to work on the pathophysiology cases. There might be students on the waiting room. Okay, how do I get them in? Let me see. Stop sharing here. Go admit all. Okay, there you go. Is anybody else waiting on the waiting room?
Yes, there are two members from my group are waiting.
Okay,
Also.
I put them in. Okay, so we're good. Okay, I think everybody's in now. Okay, great. Okay, so let's get started. And that was the Blackboard thing I wanted to talk about. And go ahead and start the review. As I told you before, it's based on the study guide. So I really recommend you to print the study guide, okay? Print it and go over it because it's very easy. What I'm going to do today is go through the number 1 up to number 21 item in the study guide and go through that using our PowerPoint to do this review. So the first one is identify the general organization of the GI system. Usually people tend to realize that, oh yeah, the GI system, it goes from the mouth to the anus and that's all. It's a tube, and they tend to forget that we have accessory organs and have so much importance. It's not only a tube, it has more functions that we realize it does. It has implications in the immunology system. It has implications in the neurology system. It has implications in our emotions. I mean, and also it has implications in, like, for example, right now, the GI system is related with dementia. So make sure not to subestimate the importance of the GI system. So gastrointestinal system, yeah, it's true. It starts in the mouth and it goes down like a tube, but we also have in the mouth accessory organs like a teeth, tongue, salivary glands. And if you go downwards, we're going to have the pancreas, we're going to have the liver, the gallbladder, and of course, the GI has its own organization. Each part of the tube has different functions and it has different names. So understanding the main functions of the gastrointestinal system is going to be pointed out basically on slide 5, but also throughout the PowerPoint. Slide 14 indicates the ingestion of the oral phase, where we form the bolus. From slide 29 to 32, we talk about digestion, stomach, forming the chyme. And from slide 35 to 36, the main function of the small intestine is the absorption. But make sure also to know that in the small intestine, we have the Peyer's patches. Peyer's patches are in per se an immunological organ, and it does intervene in infections, specifically infections that are coming into the body through the GI. In slide 56 to 60, it's talking about the large intestine where it's produced the excretion, but also remember that we have the microbiota or the microbiome that is also called the good flora or the good bacteria that also has a lot of implications with dementia and the produce of other diseases, especially chronic diseases. So some people says that also microbiota has to do with diabetes type 2. Okay, so going on, just to review the functions of the gastrointestinal system, are going to be ingestion, digestion, absorption, and excretion. And of course, here in this slide, you can see where does occur each one of them. And we're going to have ingestion do basically in the oral phase and done by the salivary glands, where it starts the digestion of the food. Okay, identify the salivary glands in its main function and the production of the bolus. Also, remember that amylase is part of the saliva and it breaks down carbohydrates. We have main three salivary glands. We already went through this in anatomy, the parathyroid, the submandibular, and the sublingual. And interpret the layers of the GI system and its function in slide 10 and 15. This is basic, and it's basic because it's talking about the organization by layers. And this is very, very important. So in general, we are going to have the layer called mucosa. That's at the same time divide in three parts, epithelium, lamina propria, and muscularia of mucosa. That layer is going to be responsible in contact with the food, and it's going to be responsible for the first absorption of nutrients, right? Right under the mucosa, we have the submucosa, where we find the first plexus. That plexus has like two different names, Meissner or submucosal plexus. We can use both of those names. And immediately after, we have a layer that's called musculari propria. Musculari propria has two layers at the same time, the circular and the longitudinal muscle one. In between those, we have the Auerbach's or myenteric plexus. Also, you can use both names, okay? Usually they use a lot myenteric plexus because it's the most common name, but you can use whatever you want. The important thing is that it is between the two different types of fibers of muscle, okay? And after that, of course, in contact with the outside of the GI, it's the serosa or adventitia that's in close contact with the peritoneum. Okay, let's go here. This Meissner plexus, it's going to be responsible for this secretion in the GI. And the myenteric plexus basically is going to be responsible for the motility function of the GI. Okay, then the movements. Movements are important in the GI, and we need to correlate those with the each one of the layers of the muscles. And specifically, movements will help progress the bolus through the esophagus and also progress the chyme after through the small intestine. So we have in general, almost all GI has the same layers. There's only one exception. The exception is going to be the stomach that has an extra oblique muscle layer. But in general, we have an inner circular layer, this one here. It's going to contract behind the food, okay? And we have, after that one, an outer longitudinal muscle, okay? And I mean, the muscularia externa has the inner circular muscle and the outer longitudinal muscle. That muscularia interna is like the outer layer. It will relax and it will pull forward the food. Okay, so basically I would like you to know that the inner circular layer will contract behind the food and it will produce a propulsion, and the longitudinal one, it's the one it's going to relax also and it will pull. those two movements will do what we call the peristalsis. Okay, the oblique smooth muscle, of course, the stomach is handling a lot of stress due to the acid. So this additional layer of muscle, it's there because it's needed, because it's where the gastric acid is produced, and also because of the movements that the stomach does during the digestion. So that's the extra smooth layer called oblique. Let's go and move on and differentiate the functions and location of the plexus as internal innervation of the GI and external innervation of the GI. So these are the slides where it's indicated from 10 to 65. And I just want to mention here, for example, on the right panel, we have, on this side, we have like an intrinsic nervous system. That was one of the questions in our pool. Yes, the GI has its own nervous system, and of course is located in the mesenteric and also in the submucosal plexus that we talked about. And each one, the submucosal one, is responsible for secretion, and the mesenteric plexus is responsible for peristalsis. Also, that's inside the intestine, right? That's inside the layers, that's inside the GI. But this one, this intrinsic nervous system connects to the extrinsic neurons, right? And there is a very good way of organizing this. Usually, we have the vagus nerve, right? We can have for the stomach, for example, we have the sympathetic chain, also for the stomach, the intestine, the large intestine, and in the lower part of the rectum, we have the pelvic nerve. Okay, we already talked about this. This is just going back, indicating where is it located, the mesenteric or Auerbach plexus. And it's the one that relaxes and it contributes to peristalsis. Also remember that we have sphincters in the esophagus, and we have other sphincters like the pyloric sphincters in the stomach, and those are also innervated by a vagus nerve. Okay, let's continue and talk about afferent and efferent and the sphincters. Like, for example, lower esophageal sphincter is basic knowledge in order to understand some of the disorders like achalasia. So let's take a little while and get here and describe this. So this that we see here on the side is the diaphragm. Remember that when we talk in anatomy about the diaphragm, we have a crural part of the diaphragm that is it's innervated by the phrenic nerve, right? Take a look here. Phrenic nerve is going to use acetylcholine neurotransmitter, okay? That's part of the lower esophageal sphincter. That's the outside of the lower esophageal sphincter, okay? But in the inside, we have other fibers here that are circular fibers, okay? Those fibers inside of that sphincter are going to be innervated by the vagus nerve. And the vagus nerve is going to use also acetylcholine, preganglionic, but postganglionic is going to use VIP and nitric oxide. VIP is vasoactive intestine peptide. Okay, so it has different neurotransmitters. Okay, and lower sphincter has like double fibers, and double innervation. Okay? Any questions about this so far? And each one is going to have different functions that we're going to cover tomorrow. Okay? Like, for example, when you have achalasia, for example, and we're going to talk about this, it's going to have a problem of relaxation. So that has to do with the vagus nerve. Okay. So vagal efferent fibers will communicate with the mentoric neurons that will mediate the lower esophageal sphincter relaxation, right? So if you have a problem of relaxation, it has to do with vagus nerve, okay? So please do not confuse this with phrenic, okay? It's not phrenic nerve. It is the vagus nerve. And the postganglionic neurotransmitter is going to be VIP and NO, that's nitric oxide. Those two neurotransmitters are the ones that has to do with relaxation of the lower esophageal sphincter. Remember that when a person is swallowing, that sphincter has to relax in order to the bolus to go and continue and enter the stomach. Any questions so far? Because this is a key concept. You can open up your microphones. I'm not right now seeing the chat. Okay. I hope there's no questions because I don't see it. So in this slide, it's just mentioning again each one of the neurotransmitters and the two components. The other thing that's important is that in resting conditions, the lower esophageal sphincter maintains a high pressure of 15 to 30. Anything about that pressure, it's not going to be normal, even though we have a variability between individuals. Okay. Okay, discuss the importance of the presence of different epithelium in the gastrointestinal junction. So the gastroesophageal junction. So we have a transition line called C line, and we have two types of epithelium. We have an epithelium that is part of the esophagus, and it's normal for the esophagus, but when it comes into the stomach, it changes. Melanie, give me just 1 minute. So the esophagus has a keratinized stratified squamous epithelium. Sorry, non-keratinized stratified squamous epithelium, but the stomach handles acid. So that epithelium needs to be different. And it's different. It's going to be, if you see it from here to here in the transition, you're going to be like more round things. That's the columnar epithelium cells. Stratified squamous epithelium, we have it also in the skin, but in the skin is keratinized. In the esophagus, we cannot have keratin. So it's non-keratinized. Okay, what's your question, Melanie?
I'm sorry, Dr. Chacon. It's because the PowerPoint slide that you uploaded, it doesn't, like, it has the similar slides, but we don't have some of those slides on the PowerPoint.
Okay,
so
I'm
different.
following. Yeah, okay. So this one I'm going to publish after. I'm just doing the review right now. I'll publish this one exactly after, but all the slides, almost all the slides are there, are the same. I just want you to focus and put attention right now. That's why I didn't publish it. I want you to put attention. Okay. And take notes if you want. You're going to have this afterwards. Okay. But I want you to put attention. So the long extend PowerPoint is there. I'm just focusing on doing a review. So I'm going to go very, like I'm going a little bit rapid, but I want you to put attention. And if you have questions, stop me, okay? Open your microphones, okay? Okay, so what is the importance of having two different epitheliums there? I mean, what is important for us as clinicians and as future PAs? Well, if we have a chronic exposure to gastric acid, and because we have a GERD, a gastroesophageal reflux, and that acid is in contact with the esophagus, and the esophagus has an epithelium that's not prepared to receive that amount of acid, what do you think is going to happen? We're going to have changes in the epithelium. That prolonged exposure to gastric acid in the esophagus is going to make changes. And that changes is what we call a Barrett esophagus. Okay. So that is the importance to know that one epithelium is non-keratinized, stratified squamous, and the other one is a columnar epithelium. The columnar epithelium is to support the acid of the stomach, but not the esophagus. The esophagus does not support that, and we're going to be having changes, metaplasia, dysplasia, and cancer. So Barrett esophagus is the first step before cancer. Got it? And esophagus cancers is a very serious condition. Okay, let's do a checkpoint number 1 for GI today. If we have a 54-year-old man that presents concern over increasing chest pain, that it worsens at night after eating, the physician refers him to the endoscopic clinic and they visualize an esophagus. They take a biopsy of the distal portion, and the pathology team reports evidence of cells that should not be there. Which of the following describes the finding of that pathology team? Well, A, B, C, D, or E, you can put it on the chat. What are they finding? Are they finding chief cells? Oh my God, chief cells are not there, right? Parietal cells, no, that's a stomach. Keratinized, skin is keratinized. No, so it's not B. Non-keratinized. That's what we have in the esophagus, but we're asking about the ending. Okay, E, exactly. That's the answer. So we're having some things, epithelium of the columnar that should not be there. And that's the first step for Barrett's esophagus. And this is the answer. You can review it in your PowerPoint. Okay, identify the main parts of the stomach and also specialized cells and the secretion of each one. Do I need to learn that? Yes, you need to learn that, please. So the way that I can show you, you can learn, I just organized this a little bit better. You have a body of the stomach and you have an antrum, right? On the body, you have the parietal cells and the sheath cells that are not indicated here. Parietal cells are the ones responsible to secrete HCl or chloric acid, and the sheath cells are the one that secretes pepsinogen, right? That has to do with proteins. And in the antrum, you have the ones that secretes the mucus cells, secreting mucus, secreting cells, and bicarbonate, because in the antrum, we need to raise the pH of the chyme before entering the duodenum, okay? And we also have G cells. G cells are located also in the antrum and they secrete gastrin. Gastrin goes to circulation, stimulates the ECL cells, which at the same time they produce histamine, and histamine are also stimulating the parietal cells to produce more chloric acid. So I think this picture is great. Is also indicating the stimulation of the vagus nerve over the cells of the stomach to produce acid. And also remember that we have these cells that also produce somatostatin, stimulated by the vagus nerve. This picture also is showing the pyloric sphincter here that it's the entrance to the duodenum. Remember that we also have other cells in the duodenum that secretes other hormones. We're going to go over those. So the function of the pyloric sphincter basically is at the bottom of the stomach, and it's a muscular valve, and it will open whenever the chyme is ready to go inside the duodenum. And what its main function is not letting the food go out until it's ready to go out. Okay. The vagus nerve is a parasympathetic autonomic innervation. Okay. Remember, vagus nerve is cranial nerve number 10. And also it has an action over the pyloric sphincter. It relaxes and it's commanded by the parasympathetic nervous system. Okay. Identify the main parts and function of the small intestine. We have duodenum, jejunum, and ileum. Each one has its specific action. I want just to comment that in the ileum, we have the Peyer's patches. That's a high concentration of lymphoid tissue there. The absorption, of course, mostly on the duodenum, right? The small intestine has a specific organization whereby villi, microvilli, and Brunel glands in the submucosa, specifically more in the duodenum. So when we talk about villi, it's like the little big, huge finger. But if you do like a microscope here, you're going to see the microvilli here. So that what its function is to maximize the absorbent surface. That's why we absorb the majority of the water and nutrients in the small intestine. And also we have the Brunel glands in the small intestine that are responsible for neutralizing acidic gastric secretions. And also this specific, when we see globate cells, we know we are in the small intestine. Also the organization in crypts of liver cone that has a lot of other cells into crypts. So this is like a specific histology of the small intestine. When we see the globate cell, this is a tissue of small intestine. They secrete mucin and they secrete mucus, and they protect against excessive acid. Okay, identifying the main enzymes in the brush butter. Brush butter also are in the intestine, small intestine. In the brush butter, we have a lot of enzymes. We have maltose, sucrase, and lactase. All of those enzymes produce glucose at the end. We have peptides that has to do and produce amino acids from the protein, right? We have also, we can produce in the lymphatic, the fatty acids and glycerols are absorbed there. And I want just you to have an idea of the brush butter enzymes in the, and for example, maltose digests disaccharide maltose into two molecules of glucose, sucrase, glucose and fructose, lactase produces lactose into glucose and galactose. That's why I told you all the first three, they always produce glucose and other things. Glucose with glucose, or glucose with fructose, or glucose with galactose, okay? The other ones are lipase. They produce fatty acids and glycerol, peptides, amino acids, etc. Okay. The functions of the major gastrointestinal hormones, I did put the two slide together here. I want you to focus on one that's creating a lot of pharmacological drugs right now. They're working with GLP-1. Okay. and GIP. So on this part of the table, it indicates when it is released. For example, GIP is released when the oral glucose goes and the fatty acid goes up. And the function of the GIP is increase insulin synthesis and release, for example. And same way you can go and take a look at GLP-1, those two. I don't care about the other ones. On this table number 1, I would like you to focus on cholecystokinin. It is important that you know CCK. The stimulus for secretion is going to be free fatty acids in the duodenum and amino acids, okay? And the primary functions of CCK, those are important. And a little bit just to know for your general information, what is the vasoactive intestinal polypeptide? Because there's going to be a lot of drugs in the future about this. So VIP, its function is going to be relaxation of the intestinal smooth muscle and the sphincters. And it increases the intestinal secretion of water and electrolytes. So please focus basically on CCK, okay? That's it. Checkpoint number 2, GI. This is T-Wise, 52 woman that is seeing you because she has fatigue. I know everybody says that they're tired this day, but I really am. Normally, I'm a go-getter, but now I'm always looking to sit down and take a nap. She tells you that. You do a blood work, and there in her white blood cells count is normal, hemoglobin is low, and you have a mean corpuscular volume high. She did a gastrectomy, and they took from the greater curvature of the stomach was removed. So what do we have in the greater curvature there? What cells do we have there? Anyone, any guesses? What cells are important? Yes?
Yeah, parietal cells.
Parietal cells, right. And what are the parietal cells important for?
Releasing intrinsic factor.
And that's right. An intrinsic factor has to do with hemoglobin, right? Right? Hemoglobin, yes? Hematology. So yes, intrinsic factor has to do with the absorption of B12, and B12 has to do with megaloblastic anemia. And this lady has anemia, and anemia makes you tired. So yes, gastrectomy not only produces problem of anemia, it can produces also problems in our muscle because B12 has to do with muscle pain, right? So anybody that has a gastrectomy surgery needs to take B12 for the rest of their life. It's a basic concept. So the absorption of vitamin B12 has to do with the intrinsic factor. Intrinsic factor is produced by the parietal cells in the stomach, specifically in the body and the curvature of the body. Here are the parietal cells. We need that intrinsic factor to be absorbing the vitamin B12 in the terminal part of the ileum, okay, is where we have B12 absorption, but also we need a carrier for protein. That's called transcriptomin number 2. If we have any problem genetic with this protein, we can also have vitamin B12 deficiency in anemia. Okay, the function of the main pancreatic enzymes is also important. We have, please do not confuse amylase, that's salivary enzymes, with maltose or sucrase or lactose that are enzymes in the small intestine with the enzymes of the pancreatic, okay, of the pancreas. Pancreas enzymes are lipase. Also, we have pancreatic amylase, and we have trypsines or protease that are produced in the pancreas, okay? So each one of the organs, they have their enzymes. Do not confuse one with the other. The other thing, gallbladders are there. The bile, it emulsifies the fat and produce micelles, and it helps us absorb the fatty acids that we ingest. Oh, this is another sphincter that it is important. This ileocecal sphincter, it's located at the end of the small intestine, but it's also like the door of entry to the large intestine. And this ileocecal sphincter, we're going to see it. We need to look for it in any images in order to know if it's a very big emergency. We're going to talk about that when we talk about acute abdomen. So just make sure that you know that we have an ileocecal sphincter here, that it is important, very close to the appendix. Large intestine, of course, is divided by this beginning part called cecum, then the ascending colon, transverse colon. We saw that in anatomy. And then sigmoid, and the last part, the rectum. The rectum also has parts. Oh, I'm not going to go over. Let me go in order. Importance of the microbiota and the Speyer patch. We already talked about that. Microbiome. We have a lot of bacteria there. They are important not only to prevent some chronic diseases like dementia, Alzheimer's, diabetes type 2. They are there because we need it to absorb and make best use of vitamin B and vitamin K, but they also produce part of the excretion CO2, methane, and other compounds. They are there because it's part of drying the fecal matter, and also they're there because it's needed, okay? In the large intestine, we absorb still water, but less than the small intestine, okay? But we're still absorbing a little bit of water. The rectum has an internal sphincter and also an external one. The internal one is, the internal sphincter is involuntary. The external is voluntary, and they have different innervations. That you need to know. It is important. So internal ulnar sphincter, it is smooth muscle. As you see here, the internal one is smooth muscle, and it is innervated by the pelvic nerves. This is a parasympathetic fibers, and it's involuntary. You do not control that. The one that you control is the external one. It's a striatal muscles, and it's controlled specifically by inferior anal branch of the pudendal nerve. That is S2, S3, and S4. We're going to see that in anatomy. This is important that you know which one is which, okay? This defecation process has to do with constipation. So we're going to talk about constipation because the external anal sphincter is voluntary. Most of constipation patients that are young, they're constipated because when they have like the stool there, that's the first stimulus, they just voluntarily close the external anal and they don't go to the bathroom, and that's not a good habit, okay? When you need to go, you need to go. Okay, list the main arterial blood circulation for the GI. We're going to see this in anatomy. I'm not going to insist about this. I just want you to make sure that you know we have a splenic circulation, a celiac trunk, superior mesenteric, and inferior mesenteric, and each one goes to each part of the GI. But it is important to know that. That's arterial circulation. We also need to know the vein circulation and the portal circulation. Checkpoint. Where are the sinusoids present in the human body? Who knows about this? Why sinusoids? And instead of what? Why? So, by the way, this is a microphotography of a sinusoid. If you see the little holes there, They're amazing. So sinusoids, there's a why. Why are they there? And instead of what? Any guesses? Any guesses? Why sinusoids? And what is a sinusoid? So, no guesses. Okay, let's go on. So sinusoids, instead of what? Instead of capillaries. And sinusoids are the connection between little vessels, arterial vessels, and little vein vessels. Okay, this is not going on. Come on. Oh, I cannot progress. Okay. So organs like spleen, liver, bone marrow, they contain little capillary blood vessels connection of vein blood and arterial blood called sinusoids. They're bigger than capillaries, okay? They're bigger because they need some structures needs to go through that, so they need to be bigger. They have endothelium. They have a discontinuous endothelium. And there you can see the measures there. It's a little bit bigger than the capillaries, 30 to 40 microns versus 5 to 10 microns. So where do we have sinusoid? Oh my God, where I cannot go. Oh my God, we have problems with, okay. We have it in the liver, right? So the sinusoids here, if you see here, this is going to be the central vein that will feed the hepatic vein of the liver in the middle of the lobule, right? And this one, it's coming, the vein, it's coming from the portal vein, and it goes together with the hepatic artery circulation, that's arterial vein, arterial blood. So vein blood and arterial blood, they come together in the sinusoid, and then they feed the hepatic vein that eventually it will go up to the right heart through the inferior vena cava. So this is what I'm talking about. This is portal vein, and it comes in, and then it goes inferior vena cava. So let me go back. This is hepatic vein. This is portal vein. This is the one that's going to go inferior vena cava. To know the portal circulation that goes towards the heart and inside the portal vein, inside the liver, and it connects to the other veins and then to the heart. This specific circulation is very, very special for the liver. But what happens if I have an obstruction here in the portal vein? Well, guess what? If I have an obstruction here, everything will collapse. I will have a bigger spleen because it's not going in. I can have esophagic varices here. It will go up to the esophagus and it could bleed, right? So any obstruction of the portal vein will produce disorder. So that's why you need to know about the portal circulation, okay? And the organization of the liver. Okay, that is it for now. Tomorrow, I want to go I have 10 minutes. I have a little bit more. I want to go through the Nearpod a little bit, but before that, I want to tell you that I would like you to just review the PowerPoints for tomorrow. We're going to talk about cases of esophagus, achalasia, diffuse esophageal spasm, scleroderma, esophageal dysmotility. We are also going to cover the stomach things. These are the basic symptoms. We're going to talk with the cases about the why of the symptoms and the risk factors. So make sure that by small groups, you get to have this handy. See the videos for that. Take notes so you will be better prepared for the cases that we are going to go through tomorrow. And I want to take the last 10 minutes of this class to go over the Nearpods, the 31 questions of the Nearpods. By the way, we didn't do good. We didn't do good on the Nearpod. So I want to go over it, and I will publish today the answers, so you will have it there. I will also publish the PowerPoint that we used for our review, so you will have it there handy. That's important. So I'm just going over the class for tomorrow, so you will have like an idea. You also have the part of the stomach, so we need to cover that also tomorrow. But we're going to do it with the case. So let me go ahead and I have it here. Thank you for all of you that were able to answer your Nearpod on time. That's good. I'm sure it was okay there. Let's do a live participation, and you can do it again if you want. This is the number. If you do it again, it will help me know if you were able to complete all the puzzles for this Nearpod. And of course, expect at least 40%, that's around 15 questions about this part. Okay, so let's go on. Which of the following are the action of CCK? CCK is produced by eye cells in the duodenum and the ileum. Select more than one. This is the code. Let me take this out. This is the code. Haven't seen it. Okay, so CCK is very important to contract the gallbladder. It is very important to produce bicarbonate secretion. It does not accelerate the gastric emptying. The contrary. It does the contrary. It stops gastric emptying. And it does stimulate pancreatic enzyme secretion. Okay, so those three are correct. Let's go to the next one. A patient with duodenal ulcer is treated with cimetidine. Okay, cimetidine, it's a drug that inhibits H secretion by the parietal cells. Which of the following receptor is directly inhibited, and which are the potential effects of this inhibition? Remember, parietal cells can be stimulated by histamine, right? And also it's the one that produces chloric acids, right? So it does not have M3 receptors affect. This one does not have nothing to do with gastrin, so I am eliminating that. CCK receptor gastrointestinal affects the histamine. No, it does not have to do with CCK2 receptor. No, so it is only that one the correct answer. Okay, let's go to number 3. A patient with H. pylori infection develops a gastric ulcer. You're going to see this. Gastric ulcer has to do with H. pylori. It's one of the pathogenesis. Okay, and which is the mechanism of action of omeprazole. So indicating this because it is important that one of the treatment is omeprazole, but also to know that the why, right? The why. We need to reduce the acid when we have H. pylori because it's part of the pathophysiology. And it is important to know how omeprazole acts, even though it's a pharmacology question, it has to do with pathophysiology. It inhibits the bump of HK-ATPase. It's the only one correct. The other ones are incorrect. Let's go on. And this is a syndrome that we're going to talk about, a gastrinoma. It's a tumor. It's a tumor outside the GI gastrointestinal tube, but it's located in a GI organ, a pancreas, usually. And it does a lot of things. We're going to talk about that. So don't worry if you did not select the correct one. The correct one here is that this tumor will low duodenal pH. And when it does that, the duodenal pH, because it's produced so much acid, acid will come into the duodenum, right? So when we say lower pH is acidic, right? And when we have an acidic pH, pancreatic lipase does not work. And that's all the reasoning over this question. Let's go on. If we don't not finish, I'll publish this. Here, normally electrolytes and water are secreted by the intestinal crypt cells. We talked about that, right, in the small intestine. But sometimes some organisms like cholera, that's a bacteria. Cholera bacteria has a very potent toxin that stimulates secretion and produces diarrhea. And it's a very serious diarrhea. You can die. You can die with cholera, believe me. It's like when you open your faucet and it never stops, that's cholera. That's the serious diarrhea it occurs. So if we're producing a very serious diarrhea, something has to not be working. This toxin, what does? It increases the level of CAMP levels. And it's very serious. That's why it produces it never stops the diarrhea. Okay, a lot of water. And the other thing, it has to do with the subunit of GTP. Why am I insisting on this? I saw a PANCE question about this, and I was like, oh my God, they need to know at least what is happening there. And we're going to talk about this when we get to diarrhea. So don't freak out, okay? You're going to be an expert on this. At least do not confuse. It does not have to do with sodium channels. It does open sodium channels. It does not have to do with closed chloric channels. No, it has to do with other parts of this specific things that has to do with other gates. And we're going to talk about. So bear with me. We're going to get over that. The other things, parietal cells are in the stomach, right? And we talked about intrinsic factors. They produce acid and also intrinsic factors. What is the consequences? We did a checkpoint about this, and it produces megaloblastic anemia. That anemia is characterized by big, huge red cells, right? It's not because of ferropenic. No, it's not diabetes. It's not loss of appetite. Okay, next one, Hirschsprung. The Hirschsprung disease is congenital disease, and it has to do with the intrinsic nervous system. And that intrinsic nervous system is when it's absence of the nervous system has to do with the Auerbach or mentoric and the submucosal. That it is, the Auerbach is located between the two musculae, right? And the Meissner is submucosal. If you see here, Auerbach is not correct. It's not submucosal. Meissner is not in between. The only correct one is the first one, right? So it is important to know where it is located. The other thing, there is an increase of expectancy right now. So we have more constipation in the elderly. And you're going to see that constipation for elderly has to do with decrease of comorbidity. There is an error here. It has to say decrease of mobility and increase of comorbidity. Sorry about that. And the other thing is because our elderly, they have so much medications, and that medications produces rectal, motor, and sensory dysfunction there. That's part of the pathophysiology of constipation. And also how much is the time? We still have time. Carbohydrates and electrolytes needs active intestinal transport into the cell? Yes. Which one? Well, remember, glucose, it's a big molecule, and sodium, they need active intestinal transportation. Fructose, and sodium can do it by itself also. Glucose and water does not. It has to be the two of them. Fructose, no. So the only one that you can select is this one. Let me make a stop. Let me see the chat here. Where's the chat? Any questions so far? Anyone? Are you following me? We are in. Yes, any questions? Okay, somebody told me if I'm going to base the questions on the videos or on my PowerPoints. Okay, let me clarify this. My PowerPoints and the case studies are based on the osmosis videos. Okay, so everything is integrated. Everything that you see here, you're going to see it here. Okay, let's go on. 10 more questions. This one, where does the slow waves are highest? If you remember, I told you the most absorption occurs at the beginning. So this waves, the peristalsis has to be slow in the duodenum. In the stomach, there's a lot of movement. In the ileum, there's a lot of movement. In the duodenum is the slow waves highest. Okay, got it? Next, nausea. So this question is a little bit tricky because it has like 3 different parts. So when do I have nausea several hours after a meal? Or early morning vomiting? Or explosive projectile vomiting? So the way that I go through this, everybody knows early morning vomiting occurs in pregnant women. So get letter B, B, B. B has to be pregnancy. So we're going with A. Explosive projectile vomiting, that it is, it could, oh my God, let me admit this person that's coming in. That could be an emergency. That could be something that, something is occurring, that person is vomiting in a projective way. Blah. I mean, involuntary. That occurs with something that it is an emergency. Urinary infection is not an emergency. Bulimia is not an emergency. Elevated intracranial pressure, it is an emergency. And several hours after a meal, well, if we have 2 correct here, it has to be blockage of stomach or intestine, right? So the only answer is number 8. That means we have 10 minutes only. Regurgitation is an effortless movement of swallow food content or stomach acid from the stomach to the mouth. That's regurgitation, but it's never associated with nausea and retching, okay? It is important to know what's nausea, what's a projectile vomiting, what's regurgitation, okay? Which of the following could be the cause of this symptom? Regurgitation, involuntary, effortless, is reflux disease, okay? Mallory tear, it's related with upper GI bleeding. It's a tear of an endothelium of the esophagus. Gallbladder stones, nothing to do with regurgitation. This has to do with the gallbladder. Avitaminosis is a problem with vitamins. Nothing to do with this. Okay, and this is the last one I'm going to go through, unless you have another questions of any of the other ones. This is very important because when we go and get up to liver diseases, is very important from the back part of the pathophysiology to understand the difference between ALT enzyme and AST enzyme. Each one of those two enzymes are indicating that something is occurring in the liver, but one of them is indicating inside the cell and the other one surrounding the cell. So if we have higher levels of ALT enzyme compared to AST levels, what is that indicating? ALT is indicating intracellular problems in the hepatocytes. Okay? So from day 0 to day, ALT is indicating problems in the hepatocytes, inside the hepatocytes.